Another episode of XYZZ. So this is more of a follow-up from the previous video on seizures and epilepsy. So if you haven't watched that, just go and watch it, so to be able to even make more sense of what is going to be discussed in this lecture. So we'll be discussing anti-seizure drugs, and we'll be looking at the classification of these drugs, the neurochemistry underlying epilepsy, and the mechanisms of action of anti-epileptic drugs, their indications, their pharmacokinetics and adverse drug reactions, and also special considerations when giving these drugs. So we'll look at the classes of anti-epileptic drugs, and we'll start with barbiturates. An example of a barbiturate being phenobarbital. Another class is hydantoins, and here we have phenytoin, fosphenytoin, and congeners of phenytoin such as mefenytoin, ethotoin, and phenacemide. Another class is succinimides, with ethosuximide being part of this class, and this is a high-yield drug usually used for treatment of absence seizures. Benzodiazepines such as clonazepam, diazepam, lorazepam, and clobazam, and cyclic GABA analogs such as gabapentin, pregabalin, called cyclic GABA analogs because they have GABA, the structure of GABA in their structure, not because they act on GABA, just that their structure has GABA in them, gabapentin and pregabalin. And then we have deoxybarbiturates, which is just the deoxy form of a barbiturate, and an example of this is primidone. Then immunostilbins such as carbamazepine and oxcarbazepine, and aliphatic carboxylic acid such as valproate and divalproex. Then we have phenyltriazines such as lamotrigine, and finally have the newer drugs, which are also called the second gen of drugs. Whatever else was just first generation of anti-epileptic drugs. You have topiramate, zonisamide, levetiracetam, vigabatrin, tiagabine, lacosamide. Nice. So let's now look at the neurochemistry underlying epilepsy. So it's caused by a low seizure threshold, that meaning that it's very easy to reach the threshold for an action potential. So the threshold is low, so this is normal, this is low, so it's easier to reach, and you have more firing of neurons. So neurons are very easily excitable, and this may be caused by glutamate hyperfunction or GABA hypofunction. GABA is the inhibitory neurotransmitter, whereas glutamate is the excitatory neurotransmitter. So you have an overdrive of the excitatory neurotransmitter, which leads to neurons that are pathologically excitable, easily excitable, and that is a problem which causes firing and causes seizures. And therefore, for the pharmacology, the goal is to, number one, either decrease the glutamate function, so because it's a hyperfunction of glutamate, the goal is to decrease it, or to increase GABA, or to do both, to do both, to increase GABA activity so that you have more inhibition and less hyperactivity. Nice. So to be able to understand how these drugs work, we need to review the synapse, the physiology of the synapse, and the whole process of the release of neurotransmitters into the synaptic cleft and how they bind into synaptic receptors, that whole process. And this usually begins with an impulse reaching the presynaptic neuron, reaching and then causing opening of voltage gated sodium channels, which cause an influx of these positive sodium ions as well as positive calcium ions into the inside, and this does something that we call depolarization, because normally you usually have more positive ions outside and more negative ions inside. So when this channel is open, this switches, so it's called depolarization, changing of that, so where you have more positive inflow. And then This therefore causes another subset of calcium channels to also open. They are called PQ type of calcium channels, and they open and they cause exocytosis of the glutamate that is packed in vesicles. So this glutamate will bind with vesicles via a protein known as SV2A. It's synaptic vesicular protein 2A that binds to the synaptic vesicle, and then you have release of glutamate into the synaptic cleft, and then glutamate will then bind to the postsynaptic ligand gated ion channels such as AMPA receptor and NMDA receptor. AMPA usually allows entry of sodium into inside the cell, and the NMDA allows both calcium and sodium, and that will now further propagate the impulse to other neurons. And looking at this glutamate synapse now, we can try and understand the various points of action of various drugs. And remember what we said, the goal in this case is to decrease glutamate function. So every drug we'll be looking at in one way or another will be decreasing the action of glutamate. So number one, we have drugs that inhibit this voltage gated channel, so will be therefore inhibiting the action potential from being achieved. Therefore you have less release of glutamate. An example being phenytoin. You have carbamazepine, lamotrigine, lacosamide, zonisamide, oxcarbazepine, valproate, and topiramate. Nice. Next, ethosuximide also inhibits this voltage gated calcium channels that also contribute to this action potential, and that's high yield to remember the mechanism of action of ethosuximide. Other drugs that have the same dimethadione and valproate as well. And then you have drugs that will inhibit this alpha 2 delta subunit of the PQ calcium channel. This was the one that was responsible for exocytosis of this neurotransmitter, which is packaged in these vesicles. And here we have gabapentin and pregabalin. Nice. And then now we have other drugs that will another drug that will inhibit this fusion protein, this SV2A synaptic vesicle protein, and it will inhibit fusion and release of glutamate into the synaptic cleft. And a drug that does that is levetiracetam, which is a broad spectrum anti-epileptic drug. And then now glutamate in the synapse, also we'll be looking at the postsynaptic membrane. But before we look at that, you have these special channels which are called KCNQ potassium channels. Their role is usually to repolarize, so they cause repolarization, therefore just reducing the likelihood of depolarization. So you have drugs that promote or rather activate the functions of these channels, so they are open for longer, and therefore you have a state where you're less likely to have depolarization. And so therefore this effect of these drugs, rather than being inhibition, is a positive. It positively affects this, promotes the action of these particular channels. So, and the drug that does that is retigabine, also known as ezogabine, depending on whether you're in the US or in the UK. And another drug that also does this is valproate. And then now looking at the NMDA receptors, you have drugs that inhibit these receptors such as falbamate and valproate again. And then you have a drug that inhibits the AMPA receptor, which is known as perampanel. You'll notice valproate appearing quite a number of times, which is also just emphasizes how broad spectrum it is for valproate. Good. So now we've looked at glutamate and how various drugs may inhibit the action of glutamate, and now we look at GABA. And remember, now the goal in terms of GABA will be to try and increase GABA function. So first we have to try and understand the physiology of GABA at the synapse. So GABA is usually derived from glutamate through a process known as decarboxylation by an enzyme known as GABA decarboxylase, GAD. And GABA is then packaged into synaptic vesicles, released into the synaptic cleft, therefore binding to these ligand gated channels known as GABA A receptors. And then after that happens, it's released and then recycled and then taken back, reuptaken into the neuron or into the neuroglial cell, which is the astrocyte in this case, and through a channel, a transporter known as GAT1. After that, GABA is then broken down to an inactive metabolite known as succinic hexamidaldehyde through GABA-T, which is GABA transaminase, and then it's then broken down. Then now we look at the various drugs that affect GABA to try and increase the levels of GABA and how they do that. So number one, we have valproate, which stimulates the activity of GABA decarboxylase, or rather glutamate decarboxylase, therefore synthesizing more GABA, so you have more GABA action. Nice. And then you have valproate again, and another drug which is known as vigabatrin, which inhibits the breakdown of GABA. So again, the overall effect is to have more GABA, and this acts by inhibiting GABA transaminase, so therefore increasing the GABA levels. And then you have another drug which inhibits the reuptake through this transporter known as GAT1. So this drug is known as tiagabine, preventing the reuptake of GABA, so we have more time in the synapse. Nice. And then now you have drugs that promote the function of the GABA A receptor, drugs which do this are phenobarbital, topiramate, as well as benzodiazepines. So they promote their function through different ways, and how they do this, an example. So phenobarbital, which is a barbiturate, does this by increasing the duration of opening of this GABA channel, whereas benzodiazepines, it's called potentiate the action of this channel by increasing the frequency of opening. So a way to remember this, because this is high yield and highly examinable, is that barbiturates, you just say barbiturate duration, increase the duration of the opening of GABA A receptor, whereas benzodiazepines increase the frequency, so you open them more often, whereas for barbiturates you open them for longer, again potentiating the activity of GABA through this channel. Nice. So we've looked at various drugs and how they act and how they either increase GABA or decrease glutamate function. So now let's try and have an understanding of their indications. So as we discussed in the previous lecture, there are various types of seizures. You have partial seizures, generalized seizures, and unclassified seizures. So under partial seizures, we talked about simple, complex, and those that begin as partial and become secondarily generalized. And then under generalized, you have tonic-clonic seizures, and then those that just have motor manifestations such as tonic, myoclonic, and atonic. And then we have absence seizures, which is a generalized non-motor seizure, and then an unclassified category where you have infantile spasms and neonatal seizures. So let's try and look at various drugs that are indicated for different seizures. So this bracket covers just this length. So whatever is outside this bracket, that drug is either not indicated or even contraindicated for that particular use. So examples, you have phenytoin, carbamazepine, phenobarbital, gabapentin, tiagabine, oxcarbazepine, which are indicated for all partial seizures, as well as tonic-clonic seizures. The drugs in red are the newer generations, as I mentioned, and then the green is just the older generation of drugs. Nice. And then we look at absence seizures. Ethosuximide is a drug of choice for absence seizures. And then unclassified, here for this infantile spasm, we have ACTH and vigabatrin being used for that use. And then we move to the next tier, which is this bracket encompasses all types of seizures. These are therefore broad spectrum drugs such as valproate, clonazepam, lamotrigine, topiramate, felbamate, zonisamide, and levetiracetam. And then, as I said, the ones in red are the newer generation. So if that means that these broad spectrum drugs can be used for any. So if ever there is a question like which of the following drugs can be used for tonic seizures, and then the choices are just phenytoin, carbamazepine, phenobarbital, and let's say lamotrigine. You know, lamotrigine, broad spectrum, so it can be used for tonic seizures. Whereas another question like which of the following drugs is not effective in treatment of myoclonic seizures, and then there you'll have valproate as a choice, clonazepam, lamotrigine, levetiracetam, and then the last choice is carbamazepine. So the one that is not indicated for myoclonic seizures will be carbamazepine, because it is actually contraindicated in myoclonic seizures. Why? Because it even actually worsens them. So on top of not even having an effect, so it has an effect which is actually negative. So that's even important to note. So it's very important to know the type of seizures and also the type of drugs that are indicated for different types of seizures. And this scheme, I find it very useful, and you can just screenshot this and just keep it, you know. And then other indications of so in terms of status epilepticus, you have the benzodiazepines, which are used as rescue therapy. So lorazepam, diazepam, and then phenytoin and phenytoin, particularly first because it's IV, that will be preferred. And then eclampsia, the drug of choice is magnesium sulfate. Eclampsia are seizures which are related to a condition which known as preeclampsia, where you have very high blood pressure in pregnancy, and that may lead to seizures, very severe seizures, particularly after birth. And magnesium sulfate is the drug of choice in that sense. And then catamenial epilepsy, which are these seizures which are related, which is where you have seizures related to the menstrual cycle. You may have it's just trying to balance the hormones such as progesterone, so progesterone may be used, and then other drugs such as acetazolamide and clobazam. So now we look at notable pharmacokinetics of these drugs as well as notable side effects. So we start with phenytoin and congeners. Again, this is not exhaustive. It also doesn't look at all the drugs, but in the link below in the description box, I'm going to attach a summarized table with pretty much all the drugs, as well as their pharmacokinetics and notable adverse drug reactions that you can check out. So for phenytoin, you have one notable pharmacokinetic is that it has zero order kinetics. It's one of the drugs that has zero order kinetics, which basically means that its elimination is constant. So even the elimination curve is just linear, as opposed to first order kinetics, which is dose dependent, and you have like a curve, as opposed to having linear elimination. And then its IV form, as we mentioned, is phenytoin. Phenytoin itself is oral. And then notable adverse drug reactions, you have coarsening of facial features, gum hyperplasia. It's one of the three notable drugs that cause gum hyperplasia. In the comments, you can list the other two. I'd like to see that two other drugs that cause gum hyperplasia other than phenytoin. And then it's also teratogenic, causing a condition known as fetal hydantoin syndrome, which you have a cleft palate, you have a small head, hypoplastic face, so you have a characteristic faces, and then hirsutism, heart defects as well. The E just for just talking about how it's teratogenic, it's an embryopathy. And then N for neurological deficits and hypoplastic nails. So Phen is a mnemonic which can be used to remember the features of fetal hydantoin syndrome. Nice. So we look at the other drugs. So you have barbiturates and benzodiazepines. So barbiturates are CYP inducers. They induce these enzymes in the liver that are involved in metabolism of drugs. And benzodiazepines, a notable thing about them is that tolerance develops. The tolerance is reduced responsiveness of the body to a drug after repeated administration of that drug. So that is an important thing to note. And in terms of adverse drug reactions, these categories of drugs tend to cause CNS depression. As we said, they increase GABA activity. GABA is an inhibitory neurotransmitter in the CNS, which usually leads to influx of negative chloride channels, ions, which cause CNS depression. So so they may cause somnolence and just sleepiness and all that. So, and then you have skin side effects for both. And then in terms of barbiturates, they are more commonly cause physical dependence, meaning addictiveness, and then anterograde amnesia, which is a feature of more commonly seen in benzodiazepines. Next, we talk about immunostimulants. An example being carbamazepine. Carbamazepine causes autoinduction, whereby that is basically just induction of its own metabolism. And notable adverse drug reactions to carbamazepine, which is a commonly prescribed drug, is GI disturbances, cerebellar-vestibular disturbance such as ataxia, SJH, that's Steven Johnson, rash, and then hyponatremia due to SIDH, syndrome of inappropriate antidiuretic hormone, and blood dyscrasias due to bone marrow side effects of carbamazepine. Nice. And then another notable drug important to note is valproate, particularly for its many side effects. It has quite a number, and you can remember them using the mnemonic valproate. That's convenient, isn't it? And then V for vomiting, A for alopecia, L for liver toxicity, and for this liver toxicity there is an antidote known as L-carnitine for this toxicity. And then it also causes pancreatitis, low platelets, which is thrombocytopenia, and then rash, also causes obesity, weight gain rather, and then anorexia, tremors, and it's also teratogenic. It may cause neural tube defects because it has some countering effects on folate. So that's important to note, because again, just like phenytoin, this is contraindicated in pregnancy because of its teratogenic effects. And then it's an enzyme inhibitor. Just remembering that drugs like barbiturates are enzyme inducers. This one is an enzyme inhibitor. Nice. Then we talk about these drugs just for these adverse effects which are high yield in terms of vision. You have trimethadione, which is an oxazolidinedione, which causes day blindness. Day blindness, which is kind of unique because you know about night blindness, where you have in vitamin A deficiency. So this drug has particular toxic effects on cones. Night blindness is usually due to rods. This drug has toxic effect on cones, so it causes day blindness, which is also known as heterolopia, and that's unique. And then vigabatrin is known to cause bilateral permanent visual loss. So a patient on vigabatrin should be under review for the ophthalmologist. And then these three drugs, topiramate, zonisamide, and acetazolamide, have carbonic anhydrase inhibiting activity, which predisposes patients on these drugs to adverse effects such as urolithiasis, which is just kidney stones, oligohydrosis, which is decreased sweating, and so lead to heating of the body, nagma, which is an ion gap metabolic acidosis, and then acute glaucoma. And then because all of them have sulfur in their structure, they are sulfonamides. They can cause sulfur allergy in patients with that kind of allergy. And then drugs that are well tolerated include lamotrigine, levetiracetam, gabapentin, and pregabalin. Mostly the newer drugs are well tolerated. And then one thing to note about lamotrigine and levetiracetam is that they have low plasma protein binding, meaning you have high levels of them in blood, meaning they can cross, and you'll have higher levels of them in breast milk. So they will, as much as they may be ideal in something like pregnancy, they may not be very ideal in breastfeeding. So in terms of considerations, so pregnancy is one consideration, special consideration, and in this you want to choose drugs with the lowest risk of teratogenicity, such as lamotrigine and levetiracetam. And then in terms of breastfeeding, you want to choose drugs with high plasma protein binding, so that they don't cross into breast milk. And drugs such as valproate, phenobarbital, phenytoin, and carbamazepine have high plasma protein binding. So that's all for this lecture. I hope you've learned something. I hope you've enjoyed the lecture. You can give feedback, and make sure you like and subscribe and share with your friends. Thank you very much.
XYZ, XYZ.